and then we give liquid embolics. Coming to the case 1, 23-year-old male, periorbital swellings in childhood, progressively increasing size, presented with orbital pain off and on. This is a DSA image which of right ICA selected lateral view. You can easily see that there are multiple feeders from the ophthalmic artery terminating into a dilated aquatic pouch along with the venous drainage, which is both anteriorly, laterally, and posteriorly through the sinus as well. Now the ECA run is also showing that multiple feeders are terminating near this pouch, both STA feeders, distal IMAX feeders, as well as feeders from the MMA. Few of them have direct fistulous communication as well. Now in this technique, the most important thing is to analyze where you have to puncture. So we make a good assessment and judgment about the puncture site, which we do under ultrasound guidance. Particularly like in this case, we decided to puncture at this point. So under ultrasound guidance, we punctured this venous pouch with 22 gauge butterfly needle and took a DSA run through this butterfly needle to see to localize it and also to exclude any contrast extravasation at this point. That's a deep image showing the same, the venous drainage pattern. After that, we started our onyx injection in this case. It's a fast video, but you can well imagine that we are slowly building a block of onyx in this patient. First blocking the distal vascular channels, and then our aim is to get into the distal feeders from both ICA and ECA in a retrograde fashion. Sorry about this video is a bit fast, but you can easily see that the onyx will go into the feeders, like going into the MMA feeders and then retrogradely into the distal IMAX and ECA, other ECA feeders, like this. So after the end, this onyx cast is achieved. Venous outlet is completely blocked, and there is retrograde flow of the onyx into the distal feeders, MMA, distal STA, and even ophthalmic feeders. Now these are the pre and post embolization images. You can easily see that the malformation is completely obliterated. Now coming to the case number 2, 57-year-old female swelling, superior eyelid for the last 2 years, progressively increasing in size and presenting complaints of headache off and on. A right ICA, DSA, lateral view revealed a bunch of tortuous vessels in the near the orbital margins, supplied by multiple feeders from the ophthalmic artery. ECA image, selected image also revealed multiple feeders from the facial artery, from distal IMAX, as well as STA. Now again, after the clear assessment, we decided to puncture this nidus in the middle portion, and after that, puncturing the butterfly needle under ultrasound guidance, we took the run just to confirm the location as well as to exclude any extract. It's an 80 view of DSA performed through the puncture needle. It's a bit fast video. You can see the fill injection is being given, how it will fill the small area in this location. Feeders are being filled. Now filling of this part of the nidus. Now the back part of the nidus as well as the lower part. Again the back part of the nidus and the superior aspect of the nidus. So the final angiogram reveals the percutaneous embolization performed through butterfly needle shows complete obliteration of the malformation in this case. The next case is 27-year-old male patient presented with swelling for the last 1 year. There is no relation to the trauma and it is progressively increasing in size. His DSA revealed left frontal region, small AVM in this area, which is again supplied by the ophthalmic, ophthalmic figures. Careful puncture of the nidus was done in the proximal segment, considering the flow towards going backwards. So DSA run was again obtained to confirm the location as well as to exclude any extract. And then diluted glue was injected in this case. Image is a bit faint, but you can easily appreciate that controlled glue injection is being done here. And these are the final images after the glue embolization through percutaneous. Now coming to the case 4, it's again 23-year-old female presented with left auricular region swelling, from which she is bleeding off and on with skin ulceration over the last 2 years. There is trauma in the childhood as well. Her AV left PCA DSA image revealed a large auricular region AV malformation supplied predominantly by the posterior auricular artery. It's a lateral view. You can easily see the features from the posterior auricular artery as well as from the superficial temporal artery. Now, I just want to emphasize the concept that while we are performing percutaneous puncture, just see the tip of the microcatheter is there and the run is being done. It is very difficult to reach this part of the malformation and obliterate it completely through these small tiny figures. It may require multiple use of catheters, or we may be left behind some of the nidus not being filled by the embolic material or even proximal embolization. So again, in this case, we punctured this malformation with a butterfly needle under ultrasound guidance and injected glue. You can easily see the glue is being injected and how beautifully it is covering all of the malformation, feeders and everything in just 5 minutes job. And it's a final image which is showing satisfactory obliteration of the malformation. Now coming to case 5, it's 57-year-old male patient with comorbidities, long-standing swelling right here, which is bleeding off and on, again with skin ulceration, bad looking ear. These are the static images. DSA image obtained through posterior auricular artery. Just see how the dysplastic vessels and big the malformation is. So it was again punctured at 3 different sites. You can easily see the 2 needles still in the picture from which glue was injected. Third needle was injected at this place, and the glue was injected in a controlled fashion. And just see the cast of the glue in the 3D image. You can easily see the needles as well. Now coming to the case number 6, 21-year-old female patient, again auricular and posterior auricular swelling, which is progressively increasing in size, and it's a source of disfigurement in a young female. So, DS of that APU clearly demonstrate how the multiple figures are reaching the auricular and posterior auricular region and drained by a large atretic dilated tortuous vein going downwards. So it's a big swelling on her face as well and neck as well because of these atretic venous pouches. These are the lateral view clearly demonstrating auricular feeders, STA feeders. So butterfly done again, puncture done under ultrasound guidance at the selected, pre-selected locations of the malformation. And it's the second run, and now the glue injection is being done. Just see how the glue pattern is following the nidal pattern, and it is so easy. We are doing it through percutaneous glue without any danger of our catheters or etc. thing being stuck or inadvertent embolization to a different territory. Again, at the second site, needle puncture was done, and just see how the glue injection is completely covering the nidal. So this is a pre-embolization run. ECA run delayed, a slightly delayed image, and it's the blue cast, which you can easily appreciate in this. Now coming to the case number 7, it's an interesting case. 28-year-old male, left auricular swelling, again presented with skin ulceration, bleeding off and on, non-healing ulcers 1 year. Episode, he had an episode of severe bleeding last year, and it was controlled by ECA ligation. And now he is again presented with bleeding, which was managed conservatively. But now clinician, vascular surgeon asked for the endovascular treatment of this case. You see left ICL and no ECA. That means we do not have direct access to this region, which is already bleeding with skin ulceration. Right vertebral artery run was done, and which shows that through odontoid arch, ascending pharyngeal, the retrograde pacification of the ascending carotid artery beyond the point of ligation, and it is going towards this malformation